Hello everyone, so I hope you're all enjoying BCOVS so far. Thank you for coming along to my session. So I'm going to be discussing one of my PhD projects, which is investigating the refractive advice optometrists give to cataract surgery patients. So I thought I'd start off with a little bit of background why this is important. So I'm sure a lot of you know cataract surgery is the most commonly performed surgery within the UK, with over 400,000 a year. So a recent study looking at patients' experiences following cataract surgery highlighted that many patients that were myopic before surgery didn't understand the consequences of becoming emmetropic following surgery. So this mainly affected patients that wore glasses for the distance, but they didn't wear glasses for reading. And then following surgery, they now needed long-term reading glasses. So in this study, this actually made up 27% of the participants. So yeah, that's quite a large proportion of participants that aren't happy with the overall outcome of the surgery. So these are just some patient quotes in blue there, just highlighting the fact they weren't happy they lost their reading ability. They knew they had a choice, but they didn't really understand the long-term consequences of that choice, so they just reverted to whatever the ophthalmologist suggested. Another key point highlighted in that study was that patients adopt a trial and error approach in the interim period between first eye and second eye surgery. So they might carry on wearing their current glasses, they might not wear any glasses, they might patch a lens, remove a lens, just adopting a variety of different techniques. And those quotes are in red there. So I wanted to design a survey to look at these two key points. So first, looking at target refraction. So do optometrists discuss target refraction at the point of referral? And then also what spectacle advice do optometrists give in the interim period between first eye and second eye surgery? So how the survey was designed, first it just gathered a little bit of practitioner profile information. So that was how many years had the optometrist been qualified, were they a resident or locum, and also in what practice type did they work. So was it, in this talk I'm just going to cover large, multiple and independent practices, but I also had a few responses from hospitals, university eye clinics and domiciliary. The subgroups in these were a little bit too small to do any analysis, and also the referral pathways might be a little bit different in those groups. So I designed some clinical case scenarios. So the first two, patient A and patient B, were designed to assess target refraction. So patient A was a -250 myope, so they wore glasses for distance, didn't wear them for reading, so fitting that criteria of patients that tend to be unhappy with the refractive outcome of surgery. And then patient B was a monovision contact lens wearer, so they had the right eye for distance, the left eye for near, and they had spectacle independence. Patient C was designed to assess the interim period between first eye and second eye. There were two different interim periods for this, so a shorter term period of 4 weeks and then a longer interim period of 6 months. And optometrists were asked what spectacle advice would they give for these two interim periods. And then finally, they were asked how soon they prescribed spectacles following surgery. So the survey was sent to UK optometrists. They were randomly selected from the GOC register using a random number generator. They were sent an information sheet, a questionnaire, and then also a free post envelope. And an identical online version was created using Google Forms, and that was distributed on social media platforms to local optical committees and also universities. I'm sure some of you are here today who filled out my survey, so thank you very much if you did. So I had a great response rate. I had 437 responses, 359 of these were online and 78 were paper replies. I did post 250, so that's a response rate of around 33%. So that's in line with other survey studies. So on this graph, we've got the number of years qualified against number of optometrists. So as you can see, large multiples made up 45% of the responses, and median years qualified in this group was 10 years, with an interquartile range of 5 to 20 years. And then in the independent group, they made up 39% of the responses, and they had a median years qualified of 25 years and an interquartile range of 17 to 35 years. So as you can see, much higher in the independent group there. I did look at this in a little bit more detail. So in the large multiple group, 22% of the respondents did have 3 years or less of experience, in comparison to the independent group where this was only 4%. So this is patient A. This is just taken directly off the survey. So they were myopic, they wore glasses for distance, they took them off to read, they had bilateral cataracts, and you were going to be referring them for surgery. So optometrists were asked, would you discuss target refraction at the point of referral? And they were given 3 options, which were yes, discuss in person, yes, and state in referral letter, and no, they would leave it to be discussed with the ophthalmologist. So the results of that are just on this graph here. So we have the 3 options, yes, discuss in person, yes, and state in referral letter, and no, they'd leave it to the ophthalmologist on the horizontal axis. And then it's split into large multiple and independent practice types. So if we add together the yes, discuss in person and the state in referral letter, we get a discussion rate of 44% in the large multiple group. And then if we do the same in the independent group, we get a discussion rate of 80%. So as you can see, much higher in the independent group there, which left a 56% non-discussion rate in the large multiples and a 20% non-discussion rate in the independent group. So this is patient B. This was the patient that wore monovision contact lenses. So they had the right eye for distance, the left eye for near, and they had spectacle independence. Optometrists were asked the exact same question and they were given the same 3 options. So this was a more unique situation. So I was thinking that more optometrists would discuss target refraction in this case because the patient likes spectacle independence and they could potentially be a candidate for a monovision target refraction. So the results of that are in this graph here. So it's exactly the same. We have the same 3 options on the horizontal axis and split into large multiple and independent practice types. So if we look at large multiple, we now have a discussion rate of 61%. And in the independent group, we now have a discussion rate of 85%. So higher in both groups, but as you can see, still a big difference there between large multiple and independent. So looking at those graphs, we can see that large multiple optometrists discuss target refraction less, but we also have to remember that in the large multiple group, the optometrists were younger and had less experience. So the main question is discussing target refraction, is it actually linked with the practice type or is it linked with years qualified? So we did look at this using a multivariate analysis. So as you can see, there was a statistically significant association found between years qualified and discussing target refraction. And then also when we looked at this for practice type and whether the optometrist was a resident or locum, we can see that a non-statistically significant association was found there. Therefore, we can confidently say that discussing target refraction is linked with years qualified and not practice type as it first appeared in those first graphs. So along with ticking whether they would or wouldn't discuss target refraction, optometrists were also invited to give a reason for their answer. So these underwent content analysis. So this is where we look at the themes in the answers and then we see the frequency of which those themes occur. So the most common theme for both patient A and patient B was patient choice and satisfaction. So these were mainly experienced optometrists who wanted to improve the outcome of surgery for patients, and they were happy to discuss target refraction with them. There was a group found in patient B that wasn't in patient A, and that was inform the ophthalmologist. So this was where optometrists would inform the ophthalmologist that the patient wore monovision contact lenses successfully and they liked spectacle independence and they would potentially be suitable for a monovision target refraction. Obviously, when we normally refer patients for cataract surgery, we might not necessarily include any contact lens information, but in this case it's quite important because it's the patient's habitual refractive error. So patient C, this was looking at the interim period between first eye and second eye surgery. So the patient had had surgery on their right eye 6 weeks ago, so they were now able to come in for a new spectacle prescription, but they were going to be having surgery on the left eye at some point. And there were 2 periods for this, so there was either a 4-week wait for surgery on the left eye or a longer time period of 6 months for surgery on the left eye. So optometrists were asked what spectacle advice they would give for these 2 different interim time periods. So all the spectacle advice options are just on this graph here. So as you can see, the most common spectacle advice given for the 4-week interim time period was to remove the right eye lens from their current spectacles, so that was the surgical eye, and that was closely followed by the use of ready readers. So the main reason for this was that optometrists thought they were easy and convenient options and just a temporary solution really to tie the patient over until they had surgery on their fellow eye. And then the most common spectacle advice given for the 6-month interim time period was to update the right eye lens in current spectacles. So that was updating the surgical eye. Optometrists felt 6 months was too long to be given a temporary solution, and they wanted to give patients something a little bit more permanent. As you can see, wearing current glasses and patching a lens isn't advised by optometrists, but from the study that I mentioned at the start of the talk, patients do seem to do that following surgery. And then finally, optometrists were asked how soon they would prescribe spectacles following surgery. So current guidelines from the Royal College of Ophthalmologists recommends updating spectacles 4 to 6 weeks following surgery. So we recently did a systematic review and meta-analysis looking at this, and we did discover that actually refraction is stable 1 week after surgery for 93% of patients. So that has benefits for patients that are particularly left with any myopia or astigmatism following surgery, or they like the convenience of multifocal lenses. So as you can see, the range differed massively from 2 days to 12 weeks. The most common recommended time period was 4 to 6 weeks, which makes sense because it's the current guidelines and people tend to follow those. But 39 optometrists would actually prescribe sooner than the current guidelines. And when I was looking at the years of experience in these two groups, you can see that it is higher in the less than 4 week group, the less than 4 week group there. So I wanted to look at these two groups in a little bit more detail. So on the left, we have the distribution of years qualified of those that would prescribe sooner. And as you can see, 85% of those had 15 years or more of experience. And then on the right, we have the distribution of those that follow the current guidelines. And as you can see, 60% of those had 15 years or more of experience. So we did an exact Fisher's test to see if the distributions were statistically significant from each other. And as you can see, a statistically significant result was found of 0.0027. So a big difference between those two groups there. And again, optometrists were invited to give a reason for their answer. So the most common reason for answer for when they would prescribe was it was recommended practice. So that was either following the guidelines from the Royal College of Ophthalmologists or from their local hospital. The second biggest, with 21%, was that the hospital care was complete, so they were happy to prescribe once the patient had been discharged from the hospital or they'd finished using any drops that they were prescribed post-surgery. And then 8%, the smallest group, was patient needs. So the optometrists that fell into this group were the ones that normally prescribe sooner than the current guidelines. So they took into consideration the patient's lifestyle and the refractive error that they were left with. And if they felt they needed glasses sooner than 4 weeks, they were willing to prescribe. So in conclusion from the survey, we learned that discussing target refraction is linked with years qualified. And also from the content analysis, we found that experienced optometrists like to discuss target refraction with patients to improve the overall outcome. And already many experienced optometrists do already discuss target refraction with their patients. From patient C, we saw that a variety of different strategies are used in the interim period between first eye and second eye surgery. And this also seems to differ depending upon how long that interim period is. And some experienced optometrists do already prescribe sooner than the current guidelines of 4 to 6 weeks, and that has the benefit for patients that are left with any astigmatism or myopia following surgery. So in conclusion, optometrists are in a great position to improve the overall outcome of cataract surgery, whether that's discussing target refraction with patients when they're referring them, particularly patients that are myopic, so they're prepared for the conversation that they'll have with the ophthalmologist when they go to the hospital, and also giving appropriate spectacle advice in the interim period between first eye and second eye surgery. If we could determine when we can prescribe spectacles following surgery, if this could actually be sooner than the current guidelines, that has the benefit for any patients left with a prescription following surgery. And if we made these into guidelines, it would particularly help younger, less experienced optometrists or those that haven't had much experience with cataract patients. I'd like to thank you for listening, and I'd like to thank everyone who helped me with this study. So Dave Elliott, Alison Alderson, Fiona Phelan and Richard Armstrong. And I'm happy to take any questions.
Emily, that was perfect timing, dead on 15 minutes. Well done. I'm not sure I've ever managed that. Right, great. Thank you for a wonderful talk there. We've got a few questions coming up in the Q&A box, so we'll start with those if that's all right with you. And I believe Dr. Mark Dunn is around as well, in case of any extra assistance with the questions. So first question we've got here, did you find a difference in the locations across the UK because of hospital preference or something like that?
I didn't gather where, because the survey was anonymous, I didn't know where the people that were filling it out, where they were located. I could tell that there were some differences across the country, because some said that it was already part of the referral process, that they would discuss target refraction, and then I had some that said it wasn't part of the referral process, so it does seem to differ in different areas of the country.
Oh, right, okay, but that wasn't part of the official analysis so far?
No, not yet.
Okie dokie, thank you. Next up, did you look at both residual RX and those waiting for second eye to be done together?
Do you mean having surgery together at the same time?
I think so, yes.
So in patient C, they needed surgery on both eyes, but normally there's the wait in between first and second eye surgery. So, and that again depends on where you are in the country. So for some patients, they have the surgery on the second eye relatively quick, and then for others, they could be waiting months. So that's why I included those two different time periods there. But I didn't look at patients who have both eyes done at the same time.
Okay, great. The person that asked that question asked so anonymously. If that didn't quite answer the question, please feel free to leave a comment and we'll catch up on that later. And I think we've got time for just one more question. Did you ask about appointment times and whether the optometrists were part of the cataract referral scheme specifically? Was that the specific question?
Not specifically, but in the reason for, if I would ask them in the reasons for answers, lots of them did say whether they were part of a scheme. So if they did already include it as part of a scheme, and then we had some optometrists who said they just wouldn't have time to discuss that in their clinics and things. So I didn't ask specifically, but I could get a feel for it just from the responses that I got.
Yeah, so picked up a bit differently. I get it. Yeah, great. Different. Thanks very much, Emily. That's wonderful. In the interest of time, I think we're going to need to move on to our next speaker.